Good evening, ladies and gentlemen, and welcome to the Center for International Governance Innovation, or CIGI as we say. My name is Fred Kuntz. I'm the Vice President of Public Affairs here at CIGI. Thank you all for joining us at the CIGI campus for this evening's lecture. Thanks also to our public event sponsor, Wordsworth Books, for all of their ongoing support of the CIGI Signature Lecture Series. We also thank those who are joining us through our live webcast tonight. Following this evening's address, we welcome questions from both audiences here in the CIGI auditorium or through the live chat function at your screen. If you hear, there are microphones at the bottom of the stairs. Please remember to state your name and to keep the questions brief. Universal health care is something that many of us here in Canada take for granted, but affordable access to vaccines, life-saving medication, doctors, is still a distant goal for many people living in developing countries. Recently, the possibility of universal health care became a United Nations post-2015 Sustainable Development Goal. And that's been a focal, of that becoming a goal has been a focal point of discussion among many organizations, including the UN and World Health Organization. Tonight, Jeffrey Sturchio, CEO of Rabin Martin, a global health strategy consulting firm, will shed light on a key debate at the forefront of these discussions. What role should the private sector play in delivering universal health systems? Here to introduce tonight's speaker is Alan Whiteside. Alan is the CIGI Chair in Global Health at the Balsley School of International Affairs. He's the Director of the Health Economics and HIV and AIDS Research Division at the University of KwaZulu-Natal in Durban. He's also affiliated with Wilfrid Laurier's University School of International Policy and Governance. And earlier this year, Alan was appointed Officer of the Order of the British Empire for services to science and strategic interventions to curb HIV/AIDS. So please join me in welcoming Alan to introduce our speaker.
Good evening. It's a real pleasure to be here speaking in this hall. This is my first gig introducing someone, and I look forward to many more of these. Jeff Sturchio has to take credit for me coming to Waterloo. If he hadn't introduced me to some of the interesting people in this town, I probably wouldn't have come to the city. So I have to thank him for that, and so do we, for facilitating my coming to Waterloo. But it was really to come and join the Balsley School and to work in a new environment that was the pull. And I have to say, Waterloo has in no way disappointed in terms of having an opportunity to engage with a totally different group of people after 30 years working at the front line in HIV and AIDS in South Africa. Jeff also worked at the front line. He began his career as an academic. He has a PhD in history, and he then escaped, as he said, to go into the private sector, where he joined Merck and Company, where he was the Vice President of Corporate Social Responsibility, and as such we had many interactions with him over the years as we battled to get AIDS drugs to the many, many people across Africa who desperately needed them. He was crucial in setting up the African Comprehensive HIV/AIDS Partnership in Botswana, which was a partnership between Botswana government, Merck & Co, and the Merck Foundation and the Bill and Melinda Gates Foundation, which resulted in a phenomenal 90% plus people getting onto antiretroviral therapy. From there, he went to the President of the Corporate Council, whilst there he served as President of the Corporate Council on Africa, and then he joined the Global Health Council in Washington for a period. And subsequently, he went to Rabin Martin in New York, which is a New York-based global health consultancy firm, where he is now the president and CEO. He is one of those people who is a former of opinion in many ways. We're very lucky to have him here today. He is also a friend, and I have to say that he is, to my mind, a Renaissance man, because one of the things I do every time I see Jeff is ask for a list of books to read. And it is invariably wide-ranging and always, almost always, nearly always, very good. So it is a real pleasure to welcome Jeff for this evening's presentation. Thank you.
Well, thanks, Alan, for that very generous introduction. And considering that some of the more embarrassing things he might have said about me, I'm glad that he left it at that. It's really a pleasure to be here. It's my first visit to Waterloo and to CG and the Balsillie School, and I hope it's just the first of many. I've had an interesting couple of days, and I'll still be doing some things with some of the students here tomorrow, so I look forward to that. Well, as Fred alluded to already, universal health coverage is on people's minds around the world, at least people who worry about global health policy. And as the debate over universal health coverage has evolved in the past few years, a recurring point of discussion has revolved around what role, if any, the private sector should play in delivering on this aspirational goal of health systems. At the same time, this question poses a puzzle for health governance, and that's the question that I want to encourage you to consider with me this evening. The very idea of the private sector having a role in universal health coverage excites controversy in many circles. Some argue that the private sector is a pariah when it comes to public health, while others contend with equal passion that private sector solutions offer a panacea for public health systems strained to the breaking point. You know, as with many public policy questions, proper answers require perspective and an understanding of complex, uncertain realities. In recent months, the issue has been featured in the debate over a proposed framework of cooperation for non-state actors within the World Health Organization. A month earlier, UN Secretary General Ban Ki-moon took a more expansive view of the potential for private sector engagement with the post-2015 Sustainable Development Agenda. In his synthesis report on the road to dignity by 2030, he observed that business has a key role to play in the post-2015 era. Companies, he wrote, are ready to change how they do business and contribute by transforming markets from within and making production, consumption, and the allocation of capital more inclusive and sustainable. So this evening, I'll make the case that the question is not whether the private sector has a role to play in delivering improved health outcomes around the world, but rather how should the private sector engage most effectively with other partners to produce those outcomes. I'll offer a series of reflections on the issue, not a fully developed argument, but I hope you'll be sparked to argue with me in the question session at the end. And so I'll look forward to those questions and comments. Let me start by placing the topic in the context of the evolution of global health governance with some examples of recent thinking on the role of the private sector as we think about the role of health in foreign policy and international development. Then I'll offer a brief typology of private sector engagement with a few examples. Since 1990, or I should say in the 20 years after 1990 when the Millennium Development Goals clock started, the amount of money that's been invested in health, measured by official development assistance, grew from less than $6 billion to nearly $27 billion. So clearly new resources were available. And that new money brought with it a new landscape of global health actors. 2 decades ago, global health governance was managed by the World Health Organization, a limited number of bilateral donors, including, for instance, USAID and CETA here in Canada, the World Bank, and recipient governments around the world. Now we live in a much more complex global health world with new multilateral and private partners. Just for a couple of examples, the Global Alliance for Vaccines and Immunization, the Global Fund to Fight AIDS, TB, and Malaria, and the Bill and Melinda Gates Foundation didn't even exist 20 years ago. And now they're major funders, and Gavi, for instance, has helped to transform the landscape of childhood immunization around the world. They just had a replenishment in Berlin that led to billions of more dollars for immunization. The Bill and Melinda Gates Foundation spends roughly as much each year as the WHO, as all of the money the WHO invests, and they've had a transformative impact in several areas. And the private sector, both for-profit and not-for-profit, as well as non-governmental organizations and academic institutions, now also contribute billions each year to global health initiatives. The challenge is how to find better ways of managing this complexity, to make sure that the proliferation of potential allies adds up to more than the sum of the parts, rather than just competition for resources and people. In that regard, global health partnerships, which have become a fixture of this new landscape, offer an important mechanism to bring new resources and expertise to bear on the global health challenges we face. I've already alluded to a number of major initiatives in which such partnerships play a central role. the Global Fund to Fight AIDS, TB, and Malaria, and Gavi. One could add to that the Global Polio Eradication Campaign, and I'm sure you can think of many other examples. Mary Moran and her colleagues at Policy Cures have detailed the experiences of more than 60 product development partnerships around the world, and there was a collaboration led by WHO called the Maximizing Positive Synergies Collaboration that published a review of nearly 100 global health partnerships a few years ago. So it's clear from those examples that these range from large multi-sectoral collaborations like the Global Fund that address broad cross-cutting issues. Other examples include the Scaling Up Nutrition collaboration or the Global Alliance for Improved Nutrition, and they range from those to more targeted initiatives that improve access to existing interventions, develop new medicines or vaccines, or address health policy and systems issues. The diversity of these global health initiatives, though, seems to have moved ahead of our understanding of the most appropriate and efficient governance arrangements. In a useful article in the British Medical Bulletin a few years ago, Larry Gostin from Georgetown University and E.A. Mock outlined what they saw as the grand challenges in global health governance, including a lack of leadership, a lack of creative solutions aligned to new challenges, a lack of collaboration and coordination, a relative neglect of basic needs, and a lack of adequate attention to health system strengthening, and of course, the perennial need for more resources and priority setting, along with better accountability, transparency, monitoring, and enforcement mechanisms. So it's not a short list, and all of those factors come into play as we consider new roles for the private sector in global public health. So what would success in this new paradigm look like? I think we have to expect to find new mechanisms that will reflect principles of good governance, transparency, participation, and engagement. And there has to be a continued emphasis on accountability for success and failure, and better coordination and coherence. New ventures need to be adapted to this new environment with the inclusion of all key stakeholders. And what we want are all of society, not just all of government solutions. We need to keep the ends in mind and have a vision of change in which all participating stakeholders have contributed. And finally, it's not enough just to define priorities, but we have to make clear through broad participation how those priorities were set and who and how are people going to make different contributions to progress towards shared goals. So those are some reflections on governance, and now let me talk in more detail about the different roles that the private sector has been playing and why I think that it's important to explore these further. The private sector is both directly affected by the trends in global health governance I was just talking about, and also has an important role to play in developing the kind of sustainable solutions that the global community is looking for. Let's look at this from two different points of view. First, what's in it for business? But more importantly, how will the involvement of the private sector in the global health agenda assist international institutions in accomplishing the goal of improving the health of people living in developing countries and emerging markets? So first, why should the private sector care about global health? There was a UK interministerial group for global health a few years ago, and they talked about the challenge of global health more generally, saying that poor health is more than a threat to any one country's economic and political viability. It's a threat to the economic and political interests of all countries. And the UK government's Health is Global strategy proposed to use health as an agent for good in foreign policy, recognizing that improving the health of the world's population can make a strong contribution toward promoting a sustainable and prosperous global economy and to reducing poverty and inequality. Well, those comments can be extended to include the interests of companies as well. As Robert Mallet, who was at Pfizer at the time, once observed, disease is destabilizing. In the pharmaceutical industry, for example, in countries with a high burden of disease, the state of health has an impact on research priorities, on clinical trials, on the recruitment of scientists and the infrastructure in which businesses operate. The scarcity of human resources in health, which is another challenge that's well known, and also marginal health systems impose costs on multinational corporations. And as social partners in those countries, the private sector has a clear interest in working to improve global health outcomes for the benefit of their employees and families, their business partners, and the communities where they live and work. So that's part of the answer to why this is important for businesses. Let's look at it now from the other perspective. From the public point of view, is there value in private sector engagement in global health? Well, I think the answer is yes. That shouldn't surprise you. But the challenges of ill health and poverty are so complex and so resource intensive that states and other stakeholders can't tackle them on their own. It's well known, for instance, that the global community continues to face a steep hill in achieving the Millennium Development Goals. This is a set of 8 goals that were adopted by all the countries of the UN in 1990, and the clock runs out on December 31st at the end of this year. And they adopted them in 2000, but they ran from 1990 to 2015 in terms of measurement. And by the end of this year, many of the poorest countries in the world are not going to reach the Millennium Development Goals by a wide margin, although many countries will do better than we even expected. We're right now in the midst of an effort to really accelerate progress toward the MDGs. And they include things like reducing poverty, improving educational outcomes for children around the world, ensuring that fewer women die in childbirth or from complications thereof, that fewer children die before the age of 5, that AIDS, TB, malaria, and other infectious diseases are managed more effectively, that the environment that we have a more sustainable approach to the environment. And then finally, there's a goal on global partnerships to ensure that there are multi-stakeholder collaborations to try to address the first 7 goals. But there's still a challenge in reaching those, and industry can help with and has been helping with the health MDGs directly, and also by working in global partnerships to bring complementary resources and expertise to bear on the problems. As I said, the private sector has a common interest with the public sector in global health matters, in stopping avoidable illness and death, and in improving living conditions for individuals and populations, because in the end, that promotes economic growth and development, and obviously that has benefits for the conditions under which firms operate around the world. Now, businesses are already beginning to work along these lines, and public-private partnerships are important catalysts for action. I came from the pharmaceutical industry, as Alan observed, and there are many projects in HIV and AIDS, TB, malaria, neglected tropical diseases like onchocerciasis and lymphatic filariasis and schistosomiasis, and also in health system strengthening, in which companies, not only companies in the health sector, but also companies beyond the health sector like ExxonMobil or Anglo American, Unilever, Standard Chartered Bank, these companies have begun to engage more in global health matters with a variety of partners. And for the way forward, there's a growing awareness that new approaches to multilateralism are needed, approaches that incorporate both government interests and the private sector and civil society. As Michael Reich and Keizo Takemi observed in a Lancet paper on the G8 in global health, the nature of global challenges in many areas now outruns the capacity of institutions for global governance. This institutional gap represents both an opportunity and an obligation for the G8 countries as a new leverage point for global health policymaking. So I certainly agree with that. A similar comment was made a few years ago in the so-called Oslo Ministerial Declaration, in which Brazil, South Africa, Norway, and a number of other countries, including the UK, got together to comment on the relationship between health and foreign policy, and they made a similar point. Now, what does that mean in practice? It requires, I think, as I said before, a multi-stakeholder approach. It's really indispensable. And that certainly suggests that the private sector should be included in that approach. And there have been, over the past several years, encouraging signs that things are moving in that direction. The Department for International Development in the UK, for instance, championed an initiative called the Medicines Transparency Alliance, which paired up private sector partners together with DFID and with 7 countries around the world, ranging from Nepal to Peru. And that was an effort to find ways to work together on improving access to medicines and the way in which medicines were made available to a broader segment of the population in those countries. And most of the so-called H8 agencies, the health aid agencies, UNAIDS, WHO, UNICEF for children, UNFPA for population, are all beginning to engage in partnerships with the private sector. And there's growing interest among companies, both global companies and national companies, in working together with other stakeholders to improve global health. So let me turn now to look in more detail at the variety of ways in which the private sector engages in global public health initiatives. First, it's becoming clear that it's widely acknowledged as well that the private sector plays a role in many health systems around the world. Even in the UK, which has the most dedicated commitment to public sector provision that I'm aware of, private healthcare still accounts for about 1/8 of all health expenditures nationally. Over dinner, we were talking about healthcare here in Ontario, and even though some people would seem to feel that Canada is another example of a solely public system, the provision or the delivery of healthcare involves private practitioners and other private providers in a way that isn't, at least to outside observers like me, wasn't fully understood, but that's also important here in Ontario. According to an International Finance Corporation report a couple of years ago on the business of health in Africa, about 60% of the more than $16 billion spent on health in sub-Saharan Africa is private, and most of it is out-of-pocket spending by individuals, and about half of that money went to private providers. And in other parts of the world, in India, for example, the percentage is even higher. Roughly 80% of healthcare is provided through the private sector. There's a question about how that spending is regulated, what quality that spending leads to, and how much health is bought for the money. I'll come back to those questions, and I hope you'll come back to them in the discussion afterward. But now let's just take a look at what does this private health sector look like. And I realize, I'm generalizing across a very complex global phenomenon, but I want to just try to pull out some key points. First of all, the private health sector in countries around the world, particularly in developing countries and emerging markets, varies widely. It ranges from sophisticated facilities that provide care comparable to the best international standards, such as the Aravind eye care system in India, which does cataract surgery for tens of thousands of people a year, and in which the quality is every bit as good as a cataract operation you could have here in Canada. And it ranges from that kind of sophistication and quality through the many private practices of individual physicians, nurses, pharmacists, to a diverse and complicated mix of private sector facilities that include clinics, pharmacies, drug kiosks, social franchises, and even informal practitioners. In addition to direct delivery of healthcare services, there are roles for the private sector at all stages of the value chain. There are examples in distribution and retail, in manufacturing and supply of new health technologies, including medicines, vaccines, diagnostics, and medical devices, in health insurance and medical education. And we also have product development partnerships. One example is the Medicines for Malaria venture, which has done work on bringing new malaria medications to the market. And there are other partnerships like one called with GlaxoSmithKline and the Gates Foundation and a number of other partners to bring a new malaria vaccine to market. And then there are also even what are called public-private integrated partnerships and a host of other acronyms to describe the range of interactions between public and private actors in particular areas to achieve particular health outcomes. And the private sector partners in this sort of myriad of different partnerships include not only the international companies that I've used in some of these examples, but also their domestic counterparts, for-profit businesses, non-for-profit or not-for-profit NGOs, and faith-based organizations as well. For example, in a country like Uganda or in Kenya, 30 to 40% of the healthcare is delivered by a network of faith-based organizations that work very closely with the public sector in providing that healthcare. But without their help, former mission hospitals and other facilities that have been built up over the past decades, and in a place like Kenya, they have not only a Protestant health service, but they also have a Catholic health service and a Muslim health service, all of which help to provide additional resources so that Kenyans, wherever they live in the country, can get access to the kind of care they need. So those are all examples of where you have a range of domestic, international, and private sector counterparts and their public sector partners working in a variety of different ways. And the complexity of the roles that are involved, just to stay with this a little longer, is ranges widely. In African countries where, I have a fair amount of experience in Africa as opposed to Asia or Latin America. But in African countries, you can go to market stalls and people will sell everything from aspirin to any prescription drug you want to anybody who comes by with the cash they need to buy it, to ambitious contracting arrangements like the example of Netcare and Lesotho, the integrated partnership that I alluded to a few minutes ago, in which the government went beyond just encouraging a private sector partnership to build a new hospital, but they actually outsourced the provision of care in the largest hospital in Lesotho to Netcare in an ambitious program to help improve access, quality, and the efficiency of healthcare. And it also had provisions in the agreement that if Netcare wasn't able to provide at least the same level of service that the government had been able to do before, it would cost them money. And if they improved the efficiency and the quality of the services that they provided, there would be incentives to continue to affect those kinds of improvements. Another area that actually has gotten a lot of attention in recent years is social franchising. This is essentially applying the principle of commercial franchising to social businesses for health. So it offers another model for optimizing the delivery of healthcare. Patients' first point of contact in the provision of care services in many developing countries is likely to be with a private provider, but often the public sector has no way of regulating effectively the quality and costs of those services. But social franchising provides a model in which networked private health providers have a certain, are able to implement standards that lead to a certain quality of care. And there are studies now that show that it's been able to improve the delivery of health care and the outcomes of that care through that standardization and quality control. There's even an international conference on social franchising for health that's led by the Global Health Group at the University of California, San Francisco, and a web-based platform for knowledge sharing to aggregate and demonstrate best practices among 50 leading clinical social franchises around the world. And there are other examples like Population Services International, which has been a major contributor to the field of social marketing, and they now have social franchise networks that provide care to more than 13.5 million people in sub-Saharan Africa, Asia, and Latin America. So those are a couple of examples of some newer ways of organizing public-private partnerships to improve health outcomes. And as those examples suggest, robust engagement between the public and private sectors offers an opportunity to combine resources and expertise in innovative ways that are valuable in improving health outcomes in resource-constrained settings. So depending on their interests and their capabilities, businesses can collaborate with the public sector at different points in the value chain, from supply chain logistics to working with frontline health workers through improving primary care clinics to achieve better health outcomes. And in an era when there's pressure on scarce public budgets, whether you're in Cameroon or in Canada, a focus on shared priorities will help to ensure the most efficient and effective use of those available resources. Let me just digress for a minute and answer another question that often comes up when this issue is discussed. One question people often ask about private sector engagement is it sustainable? Can it move beyond just one-off partnerships to affect systemic change? So I want to just offer two examples from my own experience, and Alan mentioned one in the introduction. But one of those is in 1987, Merck Sharp and Dohme launched the first large-scale comprehensive global health initiative of its kind, the Mectizan donation program, in which the drug ivermectin, or Mectizan, was donated to treat onchocerciasis, which is also known as river blindness, in countries where the disease was endemic. And through a unique multi-sectoral partnership, which involved the WHO, the World Bank, dozens of health ministries, UNICEF, and also dozens of non-governmental development organizations and local communities, Merck has since donated more than 4 billion tablets of this medicine, worth more than $6 billion, for more than 1.5 billion treatments approved since 1987. And the program now routinely reaches over 100 million people a year in more than 125,000 communities where local health workers manage the program themselves. So I realize I've just listed a whole range of statistics, but remember the numbers were billions, and the number of people reached was over 100 million. And I just think that this is a terrific example of how these kinds of partnerships, when organized effectively, when managed intelligently and creatively, really can have a sustainable impact on public health in ways that, when this program was started in 1987, just weren't even imaginable. And the other example is the one that Alan referred to, which is the African Comprehensive HIV/AIDS Partnership in Botswana, a collaboration between among the government of Botswana, the Bill and Melinda Gates Foundation, and Merck and Company. And this partnership was designed to help Botswana transform its approach to HIV. At the time that we began the work in HAP, Botswana had the highest adult prevalence rate in the world. It was approaching 40% of adults were HIV positive. And now, it's almost 15 years later, but actually within the first 10 years, there was a remarkable transformation across the entire spectrum of prevention, care, and treatment in Botswana. And Botswana's HIV incidence declined significantly, particularly among the population of young people from 15 to 24. As Alan mentioned, they became the first country in Africa to achieve universal coverage for HIV treatment. Maternal fetal transmission is now, or the prevention of maternal fetal transmission now has about 100% coverage in Botswana. And the percentage of babies born HIV positive to HIV positive women declined from 40%, that's 2 out of every 5 babies, to less than 4%. So, those are some remarkable health outcomes, and they were achieved through this partnership. And again, in 2000, actually there's an interesting quotation about this in Gro Harlem Brundtland's autobiography. She went on a tour when she was, just before she became the head of the World Health Organization. And one of the stops on her tour to talk to leaders in countries around the world before the election at the WHO for the new director generalship, one of her stops was in Botswana, and she met with President Festus Mogae, who at the time was the president of Botswana. And I actually didn't even, I wasn't aware of this until just a couple of months ago when I was rereading part of her autobiography, and I came across this passage. And what she said was that when she met Mogae and they started to talk about the impact that HIV was having on his country, she said that he looked like a business owner who was facing liquidation. That, that's just how desperate not just Botswana was, but countries throughout sub-Saharan Africa were at the time. So that's a remarkable change in just a few years. So what with those examples and others, I just wanted to suggest that private sector partnerships with the public sector can yield scalable and sustainable and measurable improvements in public health and health infrastructure. And what are the conditions, though, that are needed to be in place for that to succeed? And I'll just mention these quickly because I want to draw this to a close so that you'll have time for questions and comments. But the first is, as the Botswana example suggests, it was largely the commitment and the force of President Mogae's personality that really helped turn the tide in Botswana, because his entire government was behind this partnership. So high-level political commitment and engagement are critical. Another thing that sounds simple, is not always as easy to accomplish, but partners need to agree on the purpose of the project and have clearly defined roles and responsibilities. A third point is that for programs like this to succeed, they should be country-led, because that's the only way really to make them sustainable over the long term. And that's not a surprising observation, but again, you'd be surprised how often people neglect that observation. And also, it's important to build local capacity at the same time. I mean, it really doesn't help if you simply parachute into a country with an idea for a partnership, set the program up, get it running, and then leave. Because in the long run, it's going to be the people who are trained to help in that program, the partners at the local level, who are really going to be able to make a difference. So it's important to train physicians and nurses who have the skills to treat and care for the patients, to build hospitals, treatment centers, and diagnostic facilities, to educate the population about healthy behaviors, and also to find the ways to deal with some of the non-medical aspects of global health problems. So it's just as important to invest in human resources and health infrastructure as it is to bring money and medicines for programs like this. Another point that's critically important is communication, continual learning, and a commitment by the partners to the partnership. Again, this sounds obvious, but it really is very powerful. And developing strong working relationships in that way is really critical because it leads to trust among the partners. And without trust, you really aren't going to have long-term success. And then finally, persistence pays off, that you just have to keep at it. You know, the HAP program has been in operation now for 15 years, and they continue to find ways to contribute. And without that kind of long-term commitment and the ability to adapt to new learning along the way, these partnerships won't have the impact on development outcomes that we would like to see. So let me conclude by asking the question, how can we encourage or catalyze more private sector engagement in development? And I think there are 5 important elements to consider. The first is to develop a better evidence base. You know, nothing persuades people to actually try a new project than some evidence that similar projects have succeeded in the past. And there's an increasing premium on demonstrating through careful studies what works best and why, particularly because you're competing for constrained resources. So armed with data and detailed case studies, advocates for increased engagement by business and health and development initiatives will have a more compelling case. You know, there are plenty of examples of this now. The UN Development Program, for instance, has a project called Growing Inclusive Markets, which has hundreds of examples of successful partnerships like this and has distilled some best practices that policymakers can turn to for guidance. And also, for instance, there's a group in Washington called Results for Development, which runs the Center for Health Market Innovations. And similarly to Growing Inclusive Markets, they serve as a clearinghouse for information on examples of health market initiatives. Second is inclusion. And again, you know, like some of my other observations, this is not particularly stunning, but it is important. And that is that the evidence shows that, you know, as I've said, the evidence shows that this kind of collaboration can increase impact. But to encourage additional private sector investment, it's important for public sector programs to actually welcome the possibility of working with the private sector. So that is not always as easily done as it is to say it, but in examples where you have seen that kind of openness to cooperation, there have been terrific results. You know, probably the best example of this I can think of is the US President's Emergency Program for AIDS relief, which has more than 700 partnerships with the private sector. And it's, you know, one of those is something called the Supply Chain Management System, which has transformed the supply and logistics around the availability of drugs in Africa. You know, at the same time, I realize there's skepticism in some circles about private sector engagement, and obviously there's a need for appropriate guidelines to avoid conflicts of interest, to ensure transparency. But at the same time, private money can help. You know, with those guidelines in place, private money can really help to enable public health agendas at a time when public dollars are getting increasingly scarce. The third point is leverage. Private investments in global health and development complement public sector investments. And collaboration in designing and implementing interventions and programs really enables you to achieve the goal I mentioned at the outset, that the whole is greater than the sum of the parts. Implementation is critical, and this is where the private sector's capabilities in management and measurement come into play. Because if what we're trying to do is to make the money work better, private sector approaches provide a pragmatic focus on understanding how to implement plans effectively, how to manage operations for maximum impact, and there's lots of room for innovation in that area. And then the fifth area is having an enabling policy environment. The World Bank, for instance, has done a lot of work on developing the private sector around the world, and in their annual report on doing business, they highlight the importance of coupling an enabling environment with a stable macroeconomic setting, a strong rule of law that supports the public interest but doesn't interfere with private enterprise, and stable financial systems and infrastructures. And in addition to focusing on the enabling conditions for doing business, governments can also help encourage public-private engagement in a number of other ways. By having an official policy of working with the private sector, encouraging dialogue and partnership, by ensuring accurate information flows about the scale and scope of private healthcare in the country. You would be surprised in some countries how little is known about what private healthcare is actually providing, although as I said before, in many developing countries, it's more than half of all of the healthcare that's available. Another way is to use registration and regulation in creative ways to support partnerships, to provide for incentives and financing and private involvement in public provision as a way of increasing the envelope for healthcare coverage. So those are some of the ways in which governments can use the policy mechanism to help encourage this kind of collaboration to improve health outcomes. And finally, let me just conclude by coming back to the question I posed at the outset. As governments gear up to fulfill their commitments for universal health coverage, what role should the private sector play? So as I've argued, the best way forward is one that combines public and private sector approaches, drawing on their complementary capabilities and resources. This can only succeed through a combination of political will, building trust, establishing common ground, defining rules and roles and responsibilities, and agreeing on the principles that should govern this kind of public-private partnership. But when those fundamentals are in place, experience shows that it's been possible to bring hope and improved health to millions of underserved people in lower and middle income countries by finding novel ways for the public and private sectors to work together toward common goals. So thanks for your attention, and I'll be glad to answer any questions that you have. So I should say, please, there are microphones on either side, and just for the webcast audience, it's helpful if you speak into the microphone. So if you have any questions, please just go over there. And we also have some questions on the internet. So why don't I start with that. Here we have a question. Have you seen examples of mistrust of foreign commercial interests hampering the potential of private engagement in development and health partnerships? And that's from John in Toronto. I think that, I could spend hours talking about some examples of that sort of mistrust. And I'll give you an example. And this is one where, there's an old saying that just as paranoids have real enemies, sometimes there is something to this. So I'm not suggesting that the private sector is always without fault, or that all of these partnerships are always going to work flawlessly and without any bumps in the road. But a good example of that kind of mistrust, and this is one that Alan Whiteside would be familiar with as well, is back in the late 90s, the global pharmaceutical industry was having, let's just say, a disagreement with the government of South Africa over the way in which intellectual property rules should be interpreted. After the parliament in South Africa passed a bill that allowed for what was known as parallel imports of medicines, that is, medicines that were not licensed for use in South Africa could be imported from other countries and sold at lower prices without the involvement of the people who own the intellectual property rights. The industry decided that they had no choice, and they sued the government of South Africa. Now, to people in the industry, they thought of this as just a technical issue. It was a question of the interpretation of a law. There were issues with the World Trade Organization, or at that time it was the Global Agreement on Trade and Tariffs, and they felt that South Africa was abrogating its obligations under the Global Agreement on Trade and Tariffs, and it was all a technical, abstract, sort of bloodless conversation, but they felt that their rights were being abrogated, and so they took action by issuing this lawsuit, or initiating this lawsuit. What people in the industry, and I was in the industry at the time, so I was actually involved in some of these discussions, what nobody realized was that activists on the other side of the issue, who were really concerned about access to a range of medicines for, especially for poor people in South Africa, and AIDS medicines were at the heart of this, because this was when the AIDS epidemic was really becoming a major challenge in South Africa and the rest of sub-Saharan Africa. But nobody realized that how this would be interpreted by activists who ultimately got the weight of global opinion moving in their direction was that the headline was "Pharmaceutical Industry Sues Nelson Mandela," and so all of a sudden something that had just been a technical issue in trade policy becomes a highly emotional, explosive issue in the public arena. In the end, what happened, and I mean it's a long story, and I won't bore you with all the details, but what happened in the end was that the industry realized that this was a losing proposition. Even if they won, it would be a Pyrrhic victory. And so after a couple of years, they finally managed a settlement with the South African government. The South African government's law went ahead. And actually, the people on the industry side who were afraid the sky was falling if that law went forward found that it actually didn't make that much difference because the challenge was that people had interpreted this as a question of patents versus patients' lives. But at that time, and by the time this was all adjudicated, it was after the Durban AIDS conference in 2000, it was a couple of years later. By that time, Thabo Mbeki was president, not Nelson Mandela. And Thabo Mbeki actually didn't think that HIV caused AIDS, and he didn't support the introduction of antiretroviral treatments in the way that others were arguing should be done. And so South Africa had other challenges than whether these patented medicines were available, and it took several years before there were political changes. The government actually put in place a comprehensive program for treating HIV and AIDS, and South Africa now has probably more people on treatment than any other country in the world. But just to go back to the question, yes, that episode of suing Nelson Mandela created tremendous mistrust, which in some circles in the South African government and South African civil society, and even in South Africa's industry, is still there. And so that's an example of how this can really become a long-lasting, ingrained set of deeply held but not always well-examined beliefs. And so what you had was people retreating into hostile political camps rather than trying to work together on a problem that everybody wanted to solve, namely helping to find ways to help people living with HIV infection to get access to the treatments they needed. In the end, it was resolved, and a lot of progress has been made. But had we been able to find ways to get around that mistrust by working together, things might have happened more quickly. So that's one example. Why don't we go over here?
Thank you. So my name is Robert Milligan. I'm a citizen who thinks across the disciplines and is very active in both my local community, and also I've been an innovator at the two universities. One of them and two of their multidisciplinary centers are there due to a large part to my catalytic efforts. I was in Africa for some time, and when I came back, among other things, I became knowledgeable in the public health field. I'm all for collaboration as being co-creators together. When you suggest business being involved more, I would say business has to be better prepared to contribute in an appropriate manner. And what I mean by that, it has to effectively incorporate more triple bottom line thinking into all its systems, including the accounting system, which plays a major control, is a major control factor. I see a lot of lip service, but I really don't see much action here. So I think this is very critical if you're going to be a good player. As businesses now, I fear that as it becomes involved, say in the healthcare delivery system more and more, it's going to become, in effect, a Trojan horse, which may take over everything. I feel business really, though it has a role to play, it has to be ready to play a larger role, and it's not. And if it isn't, and it gets involved too much, things are just going to go the way climate change is going right now, which is the current economic ideology is in effect leading to the destruction of life on Earth, just to put some context into this. So,
thanks for that comment. I mean, I completely agree with you. Business has to be prepared to play by the rules and to play in a way that's constructive. I'm a little more sanguine than you are about how companies are changing the way they do business. Alan mentioned that my last assignment when I was at Merck Sharp and Dohme was as the Vice President of Corporate Responsibility. So one of the things that we were in charge of was the annual reporting on things like environmental commitments and on commitments in global health and other things. And what companies have found, certainly was the case at MSD, and other large companies are finding that, for instance, in some ways, within the corporate world, environmental protection is actually something that's gotten more attention, in which there's more a mature evaluation of those issues than there are in some of the issues I was talking about. But what companies found is that when they put in place the kinds of controls on carbon dioxide emissions, on nitrogen oxide emissions, on water use, on a whole range of environmental indicators, it was actually better for the bottom line than when they were doing what they were doing before and emitting more carbon dioxide into the atmosphere. And so, I think companies have found from experience that the triple bottom line you referred to, that is that companies should take responsibility for returns on an investment both in financial, environmental, and social terms, is something that more and more companies really are taking to heart. And also, the other thing that's important, and I didn't really go into this much, but when you look at the way that the global economy is changing, and since I've been talking about global health issues, let me just frame this in that context. Over the next, let's say over the next 50 years, although it's certainly true over the next 20 years as well, there's going to continue to be a shift of the global economy away from North America and Western Europe to places like India, China, ultimately Sub-Saharan Africa, as well as Latin America. So models for doing business that have been developed in places like Europe and North America simply aren't working in places like China and India and Africa. And if large global companies who have large sunk costs in countries all around the world continue to do business in old ways, they're just not going to be able to reach the results they want on the bottom line, much less the triple bottom line. And so I think that there are economic trends in globalization that are pushing companies in the direction of thinking in new ways about doing business, in thinking in new ways about how to create constructive and sustainable partnerships with governments and civil society, so that they can continue to bring products and services to market, but do it in a way that is going to be sustainable over the long term. So the last thing I'll just say is that, to come back to where you started, if companies continue to misbehave, they'll find that it's not going to be very helpful to their long-term success. And so I tend to be optimistic that, more and more examples of where this kind of collaboration actually succeeds will encourage other companies to give it a try, and at the same time, it will change the environment so that older forms of behavior are just no longer accepted. So that's, maybe it's an overly optimistic view, but
Could I just briefly add that one other fault of corporations is they tend to focus, as far as the future is concerned, excessively on the next quarter, and this has a lot to do with the accounting system, and don't look further into the future and then see what the possibilities are and feed those back more on their present behavior and apply corrective action.
Yeah, that's a perfectly fair point. I would just add that it's not only corporations that have that short-term point of view. So, universities do it in some regards, governments do it in some regards. They're only looking to the next election. That criticism can be made of many institutions. Certainly the industry I'm most familiar with, the pharmaceutical industry, is probably less short-term focused than many industries, because new product development is on a scale of about 10 to 15 years. So the decisions you make today have to take into account what your expectations are about the market 15 years from now, not tomorrow or this quarter. So it's a complex balancing act, but I think those are important points.
Thank you.
So let's go on this side.
Hi, my name is Sarah, and I am currently a master's student at the Balsillie School. When you were discussing potential partners in providing healthcare services, you mentioned faith-based sector. And really what came to mind to me there is the question of, at what point does the infrastructural capacity that, for example, the faith-based sector brings become outweighed by some of their more private interests? And so I'm thinking of this from the HIV/AIDS perspective of faith being at odds with the MSM population, or the men who have sex with men population.
Yeah, well, clearly that is a challenge. I think that one thing I'd say about it is that I mentioned the PEPFAR program, and there's an interesting article a couple of years ago by Holly Burkhalter in Foreign Affairs that pointed out that probably the best explanation for why President George W. Bush implemented this unprecedented program, which is now still is the largest public health program dedicated to a single disease in history. But the reason that he probably went ahead with that program, even though they had no idea how it was going to work or what, how they were going to fund it over the long term or what sorts of scope it would have, was because of his own personal faith and the connections he had in the faith-based community in the U.S., in the conservative, Christian faith-based community, because there was a sense that there was a moral obligation to take action if they had the ability to affect this issue. And also then, to the question you posed on some of the more delicate questions around, after all, HIV and AIDS is a sexually transmitted disease, so there are all kinds of questions that emerge when you're trying to both prevent its transmission and deal with the consequences of transmission. There were issues around, some people felt that condom use was not good, that abstinence was the only thing that should be advocated, and that one couldn't support organizations that were also providing abortion services and other things. There were just a complex mix of very challenging problems. But what was interesting about that was that they still found a way to move forward on the program. And then at the country level, what was interesting is that the people who were in charge of implementing the program found ways to follow the letter of the law, but not to ignore the public health problem in front of them. Now, on other questions like so-called key populations, commercial sex workers, men who have sex with men, transgender populations, what's happening now, I think, and this is also, by the way, I think there are examples where faith-based organizations are dealing with those questions effectively as well. So it's hard, you shouldn't overgeneralize, that certain organizations or people from who approach this from a given perspective aren't going to deal with that problem. But there are, what's happening now is that there's been a growing awareness over the past 10 or 15 years that the only way to get ahead of the AIDS epidemic is to deal with the individual characteristics of the epidemic in individual countries. And so what we're finding, because there's still a huge gap in resources to deal with AIDS globally, even though the infection rates have been declining, there's still more than 30 million people living with HIV infection around the world. And actually Alan has done some very significant work on how the AIDS epidemic is hardly over, and these challenges are going to be with us for many decades yet. And so over the next 15 years, there's a new estimate by Rifat Atun at the Harvard School of Public Health that we face a gap of something like $300 billion in dealing with HIV around the world. So the point is that the only way to whittle that gap down is to make more efficient use of the resources available. And so the new strategies that are coming about are to focus on the key populations, which are actually driving the epidemic in countries around the world. So I think as that becomes the standard approach or the standard strategy within the HIV community, you'll find, at least I'd like to think that you'd find that the kind of opposition to dealing with key populations is going to become less and less of a challenge, because people will see that that's the only way to really beat the AIDS virus eventually. So, it's not, we could talk about that a lot longer, but it's a good question. So, yes.
It's Alistair Edgar. I'm here at the Balsillie School and with the Academic Council on the United Nations. Two quick questions. One is, you mentioned the Bill and Melinda Gates Foundation. Mm-hmm. And I guess my question there, to what extent, when you have that kind of money and you're bringing that kind of level of resource, to what extent do they define what the issues are going to be? Where's the balance of decision-making there? I ask that because I'm trying to work with a foundation that works in Somalia right now, another North American foundation, very well intended, very well meant, but they have an idea of what they want to spend their money on, and it's what they want to spend it on. And if you want to partner with them and you're a Somali institution, you have to partner with what they want, not what you believe you may need there. So where's the balance there? And then the other part, the other question is the UN Global Compact as a body, as an agency that tries to promote corporate social responsibility. How useful do you think that has been from your own experience?
Mm-hmm. Sure. Well, those are two good questions. Let me take the second first, and then I'll come back to the question of the impact that foundations have when they try to impose their own strategies on the challenges that they're facing with partners. The UN Global Compact was set up about 15 years ago. I forget well, actually it is 15 years ago. They're having their anniversary in the next couple of weeks. It was set up when Kofi Annan was the Secretary General of the UN, and he wanted to find a way to engage corporations around the world in the work that the UN was doing across the board. And so there was this idea that John Ruggie, who some of you may be aware of his work, he later did work on business and human rights, as a report for the UN High Commission on Human Rights. But John Ruggie was then working in the Secretary General's office and came up with this idea of putting together a compact, which would be a way of setting out a list of, or a set of principles that businesses would subscribe to, which were consistent with the UN's principles. So things like respect for human rights, respect for the right to work, respect for the environment, and a number of other principles. And then the idea was that companies would subscribe to those principles and would have an annual communication about what they'd been doing to support those principles. So it was a very light touch. It wasn't something in which you had to make firm financial commitments, in which you had to sign up to doing a particular set of things. So from that perspective, I think it's been very successful because there are literally thousands of companies who've signed up to the UN Global Compact. They have national networks where the companies get together and talk about issues on the agenda, and have actually done, I think a lot of work has been done over the past 15 years that wouldn't have happened if it weren't for the opportunity to work through the Global Compact and to engage with, it's sort of a quasi-independent group that's connected with the UN Development Program, and then the other UN agencies are involved with it. The UN Foundation gets involved in helping to support some of the work they're doing. Actually, I was, one indication of how useful I thought it was when I was at MSD, I actually drove the decision to have MSD join the UN Global Compact because I thought it would be a useful thing to do. But that's a minor footnote to all of this. So I think it's, you'll find, I believe it's coming up in a couple of weeks, the 15th anniversary. There'll probably be some interesting presentations and publications around summarizing the work that the Compact has catalyzed. And that's really the role that it's been most important as a catalyst of engaging company interest and doing it in a way that enabled companies, no matter what their business area, no matter what products and services they sold, no matter how large they were, whether huge multinationals or small national companies, could find ways to engage with the UN around these principles. So I think that was, actually a fairly astute way of setting it up. On the first question, there actually has been a lot of discussion in the global health community about the impact of the Gates Foundation, and it's interesting. When I led the Global Health Council, our main funder was the Gates Foundation. This is back in 2009 to 2011. And we had, I'd say there were probably 60 other organizations in Washington who were involved in the advocacy agenda in Washington vis-a-vis the US government. And I'm almost certain that every single one of those organizations was funded by the Gates Foundation. So it's become, because they've had cast such a wide net, it's hard to find an organization or an NGO in global health that hasn't had funding from the Gates Foundation. So the issue you've raised is a real challenge because they have a particular set of policies and strategies. They're focused on a number of areas where they're trying to really make a difference. And they have a point of view, and they have the money to back it up. And so, this question has even come up in the context of non-state actors at the World Health Organization, where people have questioned whether the Gates Foundation's support of the World Health Organization is on balance a good thing or not, because they have such a disproportionate impact on the resources that flow to global health initiatives around the world. I mean, I think, again, maybe it's just because I tend to be optimistic. I like to think that they, the fact that they've brought billions of dollars to bear on these issues that weren't there 15 years ago is a good thing. When you look at some of the major investments that the Gates Foundation has made, for instance, Gavi would not have succeeded in raising immunization rates to the extent they have if it hadn't been for the billions of dollars that Bill Gates decided to invest in Gavi. So, there are many examples like that where they really are having an important and measurable impact. Could they be more open to other points of view? I think the answer is probably yes. Do they try to do that from time to time? Yes. And it's just it's a work in progress that I think that, the more people suggest that they should be open to other points of view, the more likely it is that is to happen. And the more that they actually do that, the more they'll begin to come up with approaches that are reflective of a wider range of opinions. So I think there's a possibility of a virtuous circle in the work that they do. Okay, thanks. So we have another question from the internet here. How can the private sector contribute to improving local capacity and promotion of health programs? Does education funding play a role? I think this is really an interesting question because I was talking earlier today with people about the non-communicable disease epidemic that we face in the world. 3 out of 5 people who die every year die of a chronic disease like heart disease or cancer or a respiratory condition or diabetes. And there's hardly, if you look at the investments that are made in global health around the world, they're completely out of proportion to the global burden of disease from chronic disease. And then the reason that this question about health promotion is important is that a lot of the burden that we face in chronic disease is actually preventable. If you just get more exercise, eat healthier diets, don't drink as much alcohol, and don't smoke, you can avoid a lot of the chronic disease that is causing this global burden now. And a key element of that is health promotion and improving the capacity at the local level to encourage people to change their behaviors in ways that will be healthier and will lead to better health outcomes. And so, I think certainly the other part of the question was, does education funding play a role? And I think that, when it comes to building capacity for health promotion and for promoting health programs, there's a lot of, how can I put this? I think that most of the effort goes into what happens to people after they get ill and how they encounter nurses and doctors and pharmacists and others after you've been diagnosed with an illness and then have to be treated and hopefully get better. But there's actually a huge opportunity to use health resources more effectively if we focus more on what happens before people get ill, in helping changing behaviors so that they don't lead to chronic conditions, and encouraging people to continue those behaviors so that they'll stay well. And so that's an area where I think there are plenty of examples that we could use around how focusing, for instance, on teaching kids about healthy behaviors can be really important, because if you look at adolescent health, which is a growing focus of global health policy, many of the behaviors that lead to illness later in life begin when children are adolescents. They start to smoke, they experiment with alcohol, they might have risky sexual encounters, and all of those behaviors are things that, you'll never stop all of them. I'm not a Pollyanna, but at the same time, if there are programs where kids are educated about health in a more effective way, that will have a huge impact later in life, and it will be a hugely efficient investment of public resources. So I think the answer is that there are opportunities to do that, and also the private sector can contribute by supporting those sorts of programs in the communities, by placing an emphasis on health and wellness programs within their own institution, in workplace wellness, and that's something that I think is, we'll see more of. Now, we have a question over here again. Yes? Or I may have forgotten which side I was on, but we'll come. Oh, okay. Please, go ahead.
Thank you. My name is Peggy Snyder. My interest is in how you protect or promote the universality of healthcare as you move into public and private partnerships. And I can see that when you talk about immunization programs and when you talk about HIV programs, that there is a fair amount of universality. Earlier in your talk, you talked about a world-renowned eye clinic in India as a public-private partnership. I think some of the top, I'm not particularly experienced in this, but there is sort of a medical tourism that's happening, so that when you get a particularly renowned institute like a cataract surgery or other kinds of procedures, you will have Western populations from Western countries accessing that care. What is the assurance that the population within the country has universal access to some of those programs that are publicly, privately funded?
Yeah, that's a good question. First, just let me clarify, I wasn't suggesting that Aravind was a public-private partnership. I used it as an example of one of the ways in which the private sector is getting more engaged in providing healthcare in developing countries and emerging markets. But you raise a really important point, because it's actually only been in the last couple of years that you've seen the development of this sort of medical tourism that you were talking about, where people from Europe or North America might fly to India to have a cataract surgery or a hip replacement, or because it's much cheaper in those countries than it is at home. And so often, actually, there are examples of certainly European health systems which are reimbursing for the costs of traveling to the other country to get that care, because it's less expensive to do that than it is to try to treat people at home. But what happens with Aravind is one example. There's Apollo Health Systems, which is a series of a network of hospitals in India. There's Zakitsa, which is an ambulance service that's been set up in India to make it possible for people to get from outlying suburbs or rural areas to where the health clinics are. And what a number of these organizations do is use cross-subsidies, so that the money that people who are better off pay for their cataract surgery or for their ambulance ride or for their hospital stay actually part of that goes into a fund that is then used to subsidize care for people who are less well off. And certainly from what I know about those three examples, they take seriously the need to try to make care as broadly available as possible. The other thing I should just point out is, Aravind developed that system not by treating people from the West who were coming for cheap cataract operations, but by treating just, the population in India who needed cataract operations. And so it's only been through the efficiencies developed that they've been able to try to do some of these other things. The other more general point about this is, and several of you are economists, so you might have a comment on this, but if you look at the totality of investments that are made in a health system, and if you just assume for a minute that you're a government policymaker and you're trying to figure out the most efficient allocation of resources across the system, one of the things you want to do is make sure that people without resources, without the means, are going to be covered. And you also want to make sure at the other end of the spectrum, the elderly who may not have as much resource, who may actually have greater needs, are also covered. So what you want to do is to try to use as much of the money you have available to deal with vulnerable or underserved populations, and that leaves the huge middle class in the middle who have all kinds of needs. But you don't have enough money to fund everything, right? So one thing that happens in health systems, and many of you are much more expert in the Canadian system than I am, so you can comment on this if you want to, but what often happens in health systems is that trying to solve that dilemma of how to ensure that you have the most equitable provision of care leads to rationing, because that's the only way that people can see to actually get the most health out of the money that they have available. But when you have, as the example of Aravind shows, when you have an operation like that, which is known in the literature as a focused factory, that is, they do one thing, they do cataract operations, they're better at it than anyone else in the world, and they can do it at an extremely efficient cost, and they can just crank out cataract operations that cost much less and give you better outcomes than if any other provision of that service would give you. And in doing that, they also take pressure off public resources, which would otherwise have to go to provide those kinds of services to people. So when you look at it in the totality of how a health system operates, it seems to me that when you have those kinds of efficient operations in particular areas of private provision of care, it actually enables government planners to do a better job of using public resources for people who can't afford to take advantage of private resources. And there also are, by the way, plenty of examples, and I think this is the direction that things are going in, where the public system actually contracts out to private providers many of those services because they can do it through contracting. You can get those services at a cheaper rate than you can through the public system. So it's a way, that's another way of looking at it, that you're absolutely right that it's important to keep equity issues in mind. It's important to ensure that you're not crowding out people who need services and wouldn't be able to get them otherwise. But if you do it with those questions in mind and set up the rules of the road in a way that it enables private providers to do the things they do well, it also takes pressure off the public system and allows those resources to be allocated in a way to people who wouldn't otherwise be able to get the services in question. So, that's just a very quick summary of a very complicated argument, but I think that, that's a useful way to look at it. And then we come over here.
Hello, my name is Masaya. I'm a doctoral student here at the Balsillie School. I understand the economic argument and how it adds liquidity to an issue of scarce resources. I'm concerned about the issue of accountability, and that's one of the concerns that it's common in civil society groups, and it's particularly relevant in the area of policy, public policy, and health in particular. We have the impression that public servants have the duty, because of their job, to be accountable, which is not necessarily the case for the private sector, particularly when we're thinking in multinational scales, right, with different countries involved. I'm wondering, what are your thoughts about corporate accountability in this discussion?
It's a good question, and I think, one thing I would start by saying, and you may disagree, but I think it's true that the notion that the private sector is not accountable just isn't true, because and I don't mean to say that there aren't instances of bad behavior that occurs in the private sector, in the public sector, in civil society. So corruption and bad behavior, nobody has a monopoly on that. But the reason I said that it's not true is that if you're a multinational corporation, you obviously have to abide by the laws of every country in which you operate. And there are legal remedies for bad behavior in every country in which you operate. And it may be that, those remedies don't work in quite the same way in Nigeria that they do in New England. But nonetheless, they're there. And then also you have the fact that large corporations are also concerned about their reputation and because things that can happen that you might do in a developing country don't happen in a vacuum, particularly in the age of social media. And so, those behaviors, if people disagree with them, they can have serious repercussions on your business around the world. So that's looking at multinationals. The same kind of argument applies to every company that operates everywhere. There's always a body of law and regulation that keeps them accountable and holds them accountable in the most direct way, which is, an example of this is, some of you may be familiar with some of the recent cases in which pharmaceutical companies have been held accountable for marketing practices that ran afoul of regulations in China and some other countries. And that leads to billions of dollars of fines. And it also leads to increased scrutiny from regulators around the world. So all I'm trying to say is that if you're running a company and you're engaged in global health, and you had the idea that you could play fast and loose with the rules, that will come back and bite you in the end. So it's not a strategy that leads to success. And the strategies that lead to success are playing by the rules, trying to be a good partner, and finding ways to actually make a difference so that you end up maximizing both the health improvements that you can help make happen, but at the same time, it's also good for business. So I think that's that's certainly the way when I was leading a corporate responsibility function, that's the way we looked at it, that it was actually bad for business to act in ways that might be seen as unaccountable, and it was good for business to make sure that you were acting in ways that people saw as constructive and helpful. And obviously there are always people who have different views in the private sector, but I'd be surprised if most people, at least involved in the kind of global health work that I've been talking about this evening, wouldn't agree with that perspective.
If I may add, I'm wondering about the issue of policy choices as well. I think, as Professor Alistair mentioned earlier, in which the public can expect to have participation in the choices of which policy to prioritize instead of another. That would be another area or another dimension to think about accountability, not only thinking of ill-doing, but actually in decision-making. Do you have a thought about that too?
Yeah, well, that's actually a very good point too, and I think there my response would be that we shouldn't fool ourselves into thinking that the policy choices that most governments make these days are actually fully accountable to the public that they're there to serve. So it's a sense, but I'm not suggesting that two wrongs would make a right. What I'm saying is that I'm actually a strong believer in public engagement in policy making, in transparency and accountability through citizens. What's called citizen accountability mechanisms for government around the world, because the more governments are held accountable to what the voters and citizens who put them in power, the more they're held accountable for their actions, the better the outcomes for society. And so, and that applies equally not just to government, but it also applies to decisions made about whether the public and private sector should work together more. So I'm not suggesting those decisions should be made behind closed doors by a small cabal of people who are then going to tell the general public what's good for them. I think decisions about whether there should be more public-private collaboration should be made in the full light of day with involvement of every stakeholder who has an interest in those outcomes. And that leads to better public policy, it leads to better outcomes, and ultimately that's what's best for society. So I think it's a very important question. It's one that I would just say is not, it doesn't only apply to public-private partnerships, it also applies to public policy per se. Let's see, we have another question over here.
Sure. My name is Linda Whitaker. I'm a PhD student in accounting up the street at University of Waterloo. And I study social entrepreneurship. So in my conversations with some of the entrepreneurs around Waterloo region, of which there are a fair number in the tech sector, I asked them about what are their inclinations towards being involved in partnerships, social entrepreneurship activities, that sort of thing. And often I get the response that that they feel that it's very difficult to run a business in the first place, and that adding this extra dimension of social responsibility, CSR, or engagement with public-private partnerships is a level of complexity that they're not able to engage in. So I'm wondering if you have any suggestions about how to get, otherwise bright, talented, motivated individuals to participate in these sorts of agreements to move both the technology and the systems forward?
Yeah, no, it's a good question, and I think one of the things that I would just say to start is that the kind of collaborations, the kind of partnerships that I've been talking about are not going to be suited to every business in every context. So, and I think that people running some of these small startups are probably the best judge of whether they have the capacity or the bandwidth to try this. But that's not to say that there haven't been examples of startups in the tech sector getting engaged in this kind of work. For instance, there's an area called mobile health, which many of you may be familiar with, in which in a number of developing countries, they've actually been able to leapfrog, because, for instance, I live in New Jersey in the United States. I have better cell phone coverage in Kenya than I do in New Jersey. So that's partly just an indicator of how in parts of Africa, for instance, there's been such an explosion of mobile phone use that people in that sector have actually begun to think of ways to link it with M-Pesa, the electronic payment systems that are available in East Africa, and with healthcare clinics, so that you can actually send people reminders for care and help them pay for tests and other things just using a mobile phone. So, so if you're in the internet business or in information communications and technology, there may well be opportunities for some of these entrepreneurs to consider getting involved in that kind of work. You know, there are networks like the Global Impact Investing Network and other networks that provide resources and information about best practices and plenty of case studies for people in a variety of sectors so that they can see ways that they could be helpful. And so that, you know, that's the sort of thing that you might point people toward, just to show them how similar, you know, colleagues in the same industry at the same level of development have actually found ways to get engaged in social business. And there's also a network called Ashoka, which looks at social entrepreneurs, and Echoing Green. There's a whole, you know, there are lots of organizations like that that are there to just try to show different entrepreneurs ways in which they can follow this sort of business model. But it's the other thing, by the way, just to, you know, one last thought on this is that if you look at you know, some of the major tech operators of the past generation, people like Bill Gates, who's now put most of his fortune into the Bill and Melinda Gates Foundation, Zuckerberg, who was one of the largest private donors to fighting the Ebola outbreak in West Africa, Paul Allen, a co-founder of Microsoft, who was another one of the large private donors to the Ebola outbreak. So, you know, at a later stage in their career, they began to think of how they could use the business skills that they had and the money that they accumulated over the course of their career to do good in public health. So I think there's there are reasons to be optimistic that more people will get that bug and try to find ways to contribute. So thanks for the question. And I see that Fred's over here, so I think it's time for us to conclude. So thanks again for your attention and for those great questions. And it's really been a pleasure, so thank you.
A few quick comments before we adjourn. First of all, I want to thank you, Jeff Sturchio, again for your lecture this evening and for engaging the audience. At the outset, you noted that global health is really all of our business in a globalized world where a pandemic here can end up there overnight. And you argued the case for more private-public partnerships in delivering that health care. In doing so, you called for some of the conditions that would make that work. Transparency, governance mechanisms that foster corporate social responsibility. I especially enjoyed your call for more case studies into private-public partnerships. As a think tank, CG is always pleased to hear people suggest that better policy is informed by research. And I think we all feel better informed tonight as a result of hearing from an expert who's been at the front line of delivering private-public partnerships for healthcare in many countries for many years in the developed and the developing world. So for sharing your insights and your expertise, we'd like to thank you once again. The edited video of this evening's live webcast will be posted to the CG website. There'll be a blog there, and you can add your own comments to that blog. In the coming weeks, we invite you to join us for more public events here at the CG Auditorium. This month alone, we have on March 17th, which is a Tuesday, we have Kevin Gallagher from Boston University here to discuss the need for tougher regulation of global financial systems and the lessons in that from emerging markets. On March 26th, we're excited to have sustainability expert Johan Rockström here visiting from Sweden to discuss the important relationship between the economy and the environment. And then on March 31st, Professor Jack Goldstone from George Mason University will discuss the impact of growing population on the stability and security of our world as we approach 10 billion people. So be sure to register online for the CG Events newsletter to get information about these and other events. Thank you for coming tonight, and have a safe journey home. Good evening, ladies and gentlemen, and welcome to the Center for International Governance Innovation, or CG as we say. My name is Fred Kuntz. I'm the Vice President of Public Affairs here at CG. Thank you all for joining us at the CG campus for this evening's lecture. Thanks also to our public event sponsor, Wordsworth Books, for all of their ongoing support of the CG Signature Lecture Series. We also thank those who are joining us through our live webcast tonight. Following this evening's address, we welcome questions from both audiences here in the CG auditorium or through the live chat function at your screen. If you hear, there are microphones at the bottom of the stairs. Please remember to state your name and to keep the questions brief. Universal health care is something that many of us here in Canada take for granted, but affordable access to vaccines, life-saving medication, doctors, is still a distant goal for many people living in developing countries. Recently, the possibility of universal health care became a United Nations post-2015 Sustainable Development Goal, and that's been a focal, of that becoming a goal has been a focal point of discussion among many organizations, including the UN and World Health Organization. Tonight, Jeffrey Sturchio, CEO of Rabin Martin, a global health strategy consulting firm, will shed light on a key debate at the forefront of these discussions. What role should the private sector play in delivering universal health systems? Here to introduce tonight's speaker is Alan Whiteside. Alan is the CG Chair in Global Health at the Balsley School of International Affairs. He's the Director of the Health Economics and HIV and AIDS Research Division at the University of KwaZulu-Natal in Durban. He's also affiliated with Wilfrid Laurier's University School of International Policy and Governance. And earlier this year, Alan was appointed Officer of the Order of the British Empire for services to science and strategic interventions to curb HIV/AIDS. So please join me in welcoming Alan to introduce our speaker.
Good evening. It's a real pleasure to be here speaking in this hall. This is my first gig introducing someone, and I look forward to many more of these. Jeff Sturchio has to take credit for me coming to Waterloo. If he hadn't introduced me to some of the interesting people in this town, I probably wouldn't have come to the city. So I have to thank him for that, and so do we, for facilitating my coming to Waterloo. But it was really to come and join the Balsley School and to work in a new environment that was the pull. And I have to say, Waterloo has in no way disappointed in terms of having an opportunity to engage with a totally different group of people after 30 years working at the front line in HIV and AIDS in South Africa. Jeff also worked at the front line. He began his career as an academic. He has a PhD in history, and he then escaped, as he said, to go into the private sector, where he joined Merck and Company, where he was the Vice President of Corporate Social Responsibility, and as such we had many interactions with him over the years as we battled to get AIDS drugs to the many, many people across Africa who desperately needed them. He was crucial in setting up the African Comprehensive HIV/AIDS Partnership in Botswana, which was a partnership between Botswana government, Merck & Co, and the Merck Foundation and the Bill and Melinda Gates Foundation, which resulted in a phenomenal 90% plus people getting onto antiretroviral therapy. From there, he went to the President of the Corporate Council, whilst there he served as President of the Corporate Council on Africa, and then he joined the Global Health Council in Washington for a period. And subsequently, he went to Rabin Martin in New York, which is a New York-based global health consultancy firm, where he is now the president and CEO. He is one of those people who is a former of opinion in many
form the landscape of childhood immunization around the world. They just had a replenishment in Berlin that led to billions of more dollars for immunization. The Bill and Melinda Gates Foundation spends roughly as much each year as the WHO, as all of the money the WHO invests, and they've had a transformative impact in several areas. And the private sector, both for-profit and not-for-profit, as well as non-governmental organizations and academic institutions, now also contribute billions each year to global health initiatives. The challenge is how to find better ways of managing this complexity, to make sure that the proliferation of potential allies adds up to more than the sum of the parts, rather than just competition for resources and people. In that regard, global health partnerships, which have become a fixture of this new landscape, offer an important mechanism to bring new resources and expertise to bear on the global health challenges we face. I've already alluded to a number of major initiatives in which such partnerships play a central role. The Global Fund to Fight AIDS, TB, and Malaria, and Gavi. One could add to that the Global Polio Eradication Campaign, and I'm sure you can think of many other examples. Mary Moran and her colleagues at Policy Cures have detailed the experiences of more than 60 product development partnerships around the world, and there was a collaboration led by WHO called the Maximizing Positive Synergies Collaboration that published a review of nearly 100 global health partnerships a few years ago. So it's clear from those examples that these range from large multi-sectoral collaborations like the Global Fund that address broad cross-cutting issues. Other examples include the Scaling Up Nutrition collaboration or the Global Alliance for Improved Nutrition, and they range from those to more targeted initiatives that improve access to existing interventions, develop new medicines or vaccines, or address health policy and systems issues. The diversity of these global health initiatives, though, seems to have moved ahead of our understanding of the most appropriate and efficient governance arrangements. In a useful article in the British Medical Bulletin a few years ago, Larry Gostin, private sector engagement with the post-2015 Sustainable Development Agenda. In his synthesis report on the road to dignity by 2030, he observed that business has a key role to play in the post-2015 era. Companies, he wrote, are ready to change how they do business and contribute by transforming markets from within and making production, consumption, and the allocation of capital more inclusive and sustainable. So this evening, I'll make the case that the question is not whether the private sector has a role to play in delivering improved health outcomes around the world, but rather how should the private sector engage most effectively with other partners to produce those outcomes. I'll offer a series of reflections on the issue, not a fully developed argument, but I hope you'll be sparked to argue with me in the question session at the end. And so I'll look forward to those questions and comments. Let me start by placing the topic in the context of the evolution of global health governance with some examples of recent thinking on the role of the private sector as we think about the role of health in foreign policy and international development. Then I'll offer a brief typology of private sector engagement with a few examples. Since 1990, or I should say in the 20 years after 1990 when the Millennium Development Goals clock started, the amount of money that's been invested in health, measured by official development assistance, grew from less than $6 billion to nearly $27 billion. So clearly new resources were available. And that new money brought with it a new landscape of global health actors. 2 decades ago, global health governance was managed by the World Health Organization, a limited number of bilateral donors, including, for instance, USAID and CETA here in Canada, the World Bank, and recipient governments around the world. Now we live in a much more complex global health world with new multilateral and private partners. Just for a couple of examples, the Global Alliance for Vaccines and Immunization, the Global Fund to Fight AIDS, TB, and Malaria, and the Bill and Melinda Gates Foundation didn't even exist 20 years ago. And now they're major funders, and Gavi, for instance, has helped to
ways. We're very lucky to have him here today. He is also a friend, and I have to say that he is, to my mind, a Renaissance man, because one of the things I do every time I see Jeff is ask for a list of books to read. And it is invariably wide-ranging and always, almost always, nearly always, very good. So it is a real pleasure to welcome Jeff for this evening's presentation. Thank you.
Well, thanks, Alan, for that very generous introduction. And considering some of the more embarrassing things he might have said about me, I'm glad that he left it at that. It's really a pleasure to be here. It's my first visit to Waterloo and to CG and the Balsillie School, and I hope it's just the first of many. I've had an interesting couple of days, and I'll still be doing some things with some of the students here tomorrow, so I look forward to that. Well, as Fred alluded to already, universal health coverage is on people's minds around the world, at least people who worry about global health policy. And as the debate over universal health coverage has evolved in the past few years, a recurring point of discussion has revolved around what role, if any, the private sector should play in delivering on this aspirational goal of health systems. At the same time, this question poses a puzzle for health governance, and that's the question that I want to encourage you to consider with me this evening. The very idea of the private sector having a role in universal health coverage excites controversy in many circles. Some argue that the private sector is a pariah when it comes to public health, while others contend with equal passion that private sector solutions offer a panacea for public health systems strained to the breaking point. You know, as with many public policy questions, proper answers require perspective and an understanding of complex, uncertain realities. In recent months, the issue has been featured in the debate over a proposed framework of cooperation for non-state actors within the World Health Organization. A month earlier, UN Secretary General Ban Ki-moon took a more expansive view of the potential for